Good morning, everybody. I would like to disclose that part of the results I will show you over the next 15 minutes have been supported by small institutional grants from some companies. I think we've heard a lot about this discussion whether our patients should and how much should be spontaneously breathing and how much we should allow or we should tell the machine to take over. And I think this was nicely summarized by both Antonio and Alain. There is a good effect of spontaneous breathing on the need of less sedation, decreased muscle atrophy, better hemodynamics, and VQ matching, but there's also a risk of high tidal volume, high inspiratory pressure, asynchronous, and so forth. And I think, and there's, for example, a very interesting, nice animal study by Dr. Yoshida that shows that if you have mild lung injury and you allow the animal to breathe, it's published in Critical Care Medicine, and you allow the animal to breathe, this will improve the status of the lung injury. But if the injury is more severe and you allow the animal to breathe, the lung injury will get even worse. So we've tried to summarize this evidence, this conflicting evidence on the role of spontaneous breathing in acute lung injury, if you will, underlining that spontaneous breathing is not either good or bad per se, but it is like a double-edged sword, and we have harmful effects and good effects, and that probably we should monitor more. We know that our reference, our standard is esophageal pressure, but recently more and more techniques based on electromyographic signals have become available at the bedside. And so we have been using those techniques over the last few years. In fact, it's the most common technique nowadays to monitor electromyography of the diaphragm to measure electrical activity of the diaphragm is based on the so-called NAVA catheter, a catheter that was devised to deliver ventilatory assistance based on the electrical activity of the diaphragm. But as once Antonio said, you can do NAVA without NAVA. So you can use the catheter just as a monitoring tool without necessarily ventilating the patient with this mode. For example, it has been shown by the group of Paolo Navalesi in this very simple but I think elegant study in its simplicity that if you take a look at these pressure and airway and flow waveforms, which already can provide some information, you might think that in this case there's nothing too bad going on. Maybe those of you who are more interested in mechanical ventilations might note that there are some bumps in the flow tracing here and there, but really nothing that strikes our eye. But if we overlap the electrical activity of the diaphragm of these patients, we clearly see that on your left-hand side, the patient, the ventilator recognized every other respiratory effort of the patient. So basically, each inspiratory, the patient had many missed efforts that were not recognized by the ventilator. And on the contrary, on the right-hand side, you see that the ventilator was self-triggered. Maybe there was a small leak in the circuit, maybe there was a pressure oscillation. For whatever reason, this respiratory activity was not initiated by the patient himself or herself. And I think these examples provide good evidence that already just by looking at the tracings in a qualitative way, I would say, is useful. This is another example that comes from our own ICU. It's the example of what Alain showed you before as the so-called entrainment, where the patient is basically triggered by the ventilator. This patient was on ECMO and was on pressure control ventilation. You see that where the vertical bar is, the ventilator is starting the mechanical breath, delivering the insufflation, and after a while, I'm sorry, this is kind of slow, and after a while, the patient is triggered by the ventilator. Thank you. And it's, oh, much better. And it's activating his diaphragm to breathe. So this is another example where just by eyeball looking at the waveforms, you will notice some activity that honestly you would not have suspected by looking just at the flow and airway pressure waveforms. Another situation where electromyography of respiratory muscles can be useful besides monitoring patients' ventilator synchrony is to calculate the total pressure which is applied to the respiratory system. So we heard about that already by all the previous speakers on the importance of measuring this pressure, but I would like to show you how this can be achieved by electromyography. So to make a long story short, it has been known by classical physiology since the 50s, and it doesn't need a study to show it, that there is, for most muscles, there is a linear relationship between the electrical activity measured on the surface of the muscle and the pressure or the force that then, since we are talking about the diaphragm, translates into a pressure that the muscle is generating. And this association is linear over a wide range. And at some point, the linearity starts to be lost. But in our observations, these are three patients undergoing pressure support ventilation. As you can see, the relationship between the electrical activity of the diaphragm and the pressure generated by the diaphragm is linear. So that in a patient, if EDI doubles, Pmusc, you know that Pmusc is double. Now, where's the catch though? If you just go at the screen of your ventilator, you read 20 centimeters of water, peak inspiratory pressure, you know what that means, right? It means 20. If you read 8 microvolts of EDI, you don't know what that means. Because in a patient, 8 microvolts of EDI can be related or can translate into a relatively low pressure, and in another patient, it can translate in another much higher pressure. So this means that in each patient, the relationship between Pmusc and EAdi is relatively constant, at least during the time of measurement, but it will change a lot from patient to patient. So how can we translate from microvolts to pressure? This is the question. We have to translate microvolts into pressure because otherwise we don't know how to interpret our microvolts. And we took an approach which is maybe simple or simplistic. We decided to calculate this index. We called it PEI, Pmusc EDI index. It is sometimes also called neuromechanical coupling or neuromechanical efficiency. There's a little bit of terminology issue in this term. But basically, this number will tell you how many how many centimeters of water are produced for each 1 microvolt of EDI. How do you compute it? It's very easy. You just push an expiratory hold button. The patient will make an effort. At this stage, the Pmusc, the pressure generated by the muscles, is translated directly on the airway. So you measure it as an airway pressure swing. And simultaneously, you have the EDI swing. So the ratio between these two will let you know how much pressure the patient was able to generate by this given EDI. And so you can then apply this factor to the subsequent breathing to know how much pressure the patient is putting on the respiratory system. We propose a correction factor of 1.25 because you are measuring the diaphragm under isometric condition, but basically your Pmusc can be easily calculated just by multiplying your EDI by pay or neuromuscular coupling, if you prefer, divided by 1.25. So you have an EDI of 10, just multiply it by PEI divided 1.25, and magically this will translate into a pressure. So you are moving from an electrical signal to a pressure. And we have shown, at least in a cohort of patients, that this approach seems to provide a reasonably reliable estimate of the pressure generated by the respiratory muscles. We can also use this device to follow how our patient is doing during his or her weaning phase. This is a patient, this is back to like qualitative assessment. This is a patient on pressure support ventilation. We switch the patient to CPAP. So we remove the support from the ventilator. We just leave mean airway pressure. And of course, the work of breathing, the EDI goes up because the patient has to breathe more. But then we remove also PEEP, we put the patient on a T-tube, and look how much the breathing effort of the patient goes up. Maybe this patient had an issue, had a cardiac failure, so for any reason, removing not support, but positive pressure, mean airway pressure, put the patient under distress, and as soon as we restore the CPAP by reconnecting the patient to the ventilator, you see that immediately peak EDI drops. So this is a just qualitative assessment of the evaluation of a patient, not even connected to a mechanical ventilator. Or you can also decide to use the EDI to monitor intrinsic PEEP. What is intrinsic PEEP? During assisted spontaneous breathing, intrinsic PEEP is the amount of pressure that the patient has to generate to be able to generate a positive flow. So the patient has to drop alveolar pressure by this amount before being able to generate a positive flow. This is the gold standard measurement for PEEP-I. We thought, okay, maybe we can do the same with EDI. We call this auto-EDI, intrinsic EDI. We had to change it a lot because reviewers were not very happy. But eventually, you can see that when you apply positive and expiratory pressure, auto-PEEP drops. This is not rocket science. It has been shown by Dr. Marini many years ago. But also, EDI is going down, suggesting that indeed you can use EDI to monitor intrinsic PEEP. And in the last 80 seconds of my talk, I would like to share with you something very new we are doing. We are quite excited about that, although it's quite preliminary. We have been using a device that allows to measure EDI from electrical activity of the diaphragm from the surface. This has two advantages, is less invasive, and you can monitor other inspiratory muscles than the diaphragm. So this is an example of a good tracing where you have a good EDI signal, we have some activity coming from accessory muscles, and we have a good activity coming from the surface, from the diaphragm surface, measured on the surface. This is a less good example. And I'm sorry this is small, but it's just to show you, and this paper is submitted, so if anybody in the room is a reviewer of this paper, I will be happy to have a beer with you. be kind at us. And anyway, it shows that in all patients, there's a nice relationship between surface EDI and the standard EDI measured by the nasogastric tube. We have been looking at activation of EDI during weaning in those who fail or succeed, and also of accessory muscles. So I think that respiratory muscle electromyography is a useful tool to monitor Pmusc, to study synchrony, maybe also in the weaning setting. EDI is already available for clinical use, and SEMG is, I think, almost about to come. And having said that, I thank you very much for your attention.
Thank you very much, Giacomo. Excellent as always.
I had a good teacher then.
Any question? Please.
Thank you. Thank you for the presentation. Just two very short questions. The first one is, we know that ADI show just the crural, and we don't have the costal. Now, I've seen, I haven't seen the result, but you even look at the costal. Anyway, we know costal and crural behave very differently in different situations. So, and I read your paper, but the only concern I have, how can we infer from an electrical signal of one muscle, you know, the mechanics of the other muscle that probably is the costal actually that is making the tidal volume, is generating more esophageal pressure. So this is the first question I had. And then I can wait for the second one.
Yeah. Thank you, Giovanni. I think it's a very well taken point. I mean, there is always this issue of crural versus surface versus coastal diaphragm. I think you have to work a little bit with what you have, okay? A few years ago we had EDI, and so we've started to work with that. Maybe it's not perfect, but for us, anesthesiologists, clinicians, it seems reasonably accurate. Clearly, if you want to do a very precise physiological study, it seems like an over-approximation, but perhaps for daily clinical practice it works. And also we were reassured in seeing that in most patients in whom we had the simultaneous recordings of these two parts of the diaphragm, if you will, those were reasonably, and again, when I say reasonably, I think of the ICU environment. So it's not like a physiology lab where probably if I were to give this speech to a group of physiologists, that would be killed.
Yeah.
So, but I think your point is excellent and very well taken.
The second, I've seen you look even at the parasternal, which are quite promising, and they are probably primary inspiratory muscle like the diaphragm. Now, we dealing a lot with parasternal, and we are facing a lot of issue with the crosstalk with the surface, so we're still putting the needle because the pectoralis are noising a lot. How do you, and you cannot really filter. I mean, the surface is very dirty. It's a very dirty electrode.
Yeah, I agree. I mean, there's a point. If clearly, I didn't say that for the sake of time. If the patient starts moving, then you basically lose all your signal. That's another advantage of EDI versus surface EMG, which is very, very stable even if the patient starts to move around. Clearly, you have a phase when the patient is moving, is using other muscles. Honestly, the largest crosstalks we observed in the surface EMG is when the patient has a strong expiratory activity with the muscles of the abdomen, like obliquus, and those you see on the diaphragm signal. Those that is by far the largest crosstalk we have observed. Not as much in the intercostal, which are usually rather clean, and the other muscle, which is a little bit, which is often noisy and perhaps will drop its recording, is sternocleidomastoid, because sometimes you get good signal, but oftentimes you don't.
Okay, thank you.
Thanks.
Giacomo, last question. A question of clinical practice. In your center, what is your method to make the diagnosis of diaphragm dysfunction or diaphragm paresis in clinical practice? Do you use some surface EMG with quantitative view,
No,
qualitative? What's your
honestly,
practice?
of all the parameters that we look for, that are available, we use a lot maximum inspiratory pressure, like done with expiratory occlusion, which is like our starting point, and we more and more use the EDI, which I agree it's not necessarily an index of diaphragm injury, because you can have very high or very low EDI to, irrespective on the level of the injury. But just to manage this type of weak patients, we believe that having an EDI monitoring in place and following a little bit the evolution of EDI over the days is useful. But the short answer to your question is we look to maximum inspiratory pressure a lot, and we follow the course of that.
Okay. Very short, because very short, yes.
Thank you for the presentation. I don't know much about EDI, but many of the things you showed, I think you can do with esophageal pressure, like auto-PEEP or dysynchrony, weaning failure. I just wanted to know what you think are the differences between the two, or why EDI is better in some situations.
The two, which one?
Esophageal pressure and EDI monitoring.
No, I mean, esophageal pressure is really a much better standard, I must say. I like EDI a lot, but esophageal pressure is like the standard. So when you don't understand, when something is not clear, I think you should go back to esophageal pressure. The nice thing about EDI is that, honestly, doctors in our ICU, they use it routinely, and I have to say that it's quite easier to apply, at least in our hands, than esophageal pressure. But that remains as our reference. Thank you.